and it's Professor Dr. Sridhar P.S. Now, he's a senior consultant. Thanks, ma'am. He's a senior consultant radiation oncology person at the HCG Bangalore. I think somebody had called him an oncosurgeon, so he's still wondering whether he should be delighted or he should be dejected. So at the end of the night, at the end of the day, he's got a Cyberknife too, so he can cyberlically cut a sock across. He's got more than 150 150 index publications, 100 meeting abstracts, and more than 100 presentations in international and national meetings. As soon as he touches the mic, I will keep shut. We welcome you to Surat, sir.
I'll delay it. Thank you for the nice introduction, and good afternoon, everyone. And at the outset, I thank the organizing committee for inviting me, and especially for Dr. Neha, and share my experience. So 20 minutes is the time given. Okay. So the topic is management of oligometastatic disease, a new paradigm with Cyberknife. So we saw some of the case like discussion in the morning. So one of the things we talked about is the cancer is curable? That is one of the things what we are. And as an oncologist, we can say there are a lot of early cancers. What we are looking at is definitely 5-year survival is reached more than 80 to 85%. It's very much treatable, and curative intent is one of the intents what we would like to do it. I'm not talking about those diseases which is curative in nature. So I'm going to talk about what is oligometastasis. That is our introduction. So oligomets and SBRT by oligometastasis, and cases what we have done. So it is important to understand the cancer burden in India. It's one of the top 5 cancers. If you see, we still see the breast cancer, prostate, lung, and colon cancers and cervical cancers in the top 5 cancers, which is high and also have a high mortality. 60 to 70% of these patients will have a metastasis or a metastatic disease. At any given time, we always have more than 50 to 60% of our patients are metastatic disease. In the past, we always put this into incurable disease versus palliative care. So probably in the practice, when you see that, it's not really the truth. So in these 50 to 60%, actually around more than 50% fall into a criteria, what we call it is oligometastatic disease. So what is oligometastasis disease? If any people who have passed out recently, this is one of the examination questions, and for postgraduates in oncology, definitely is one of the examination questions. It's a burning topic as for now, and it's very important to know all of us should know about this. And an intermediate state between the local and the systemic disease, where radical or local treatment of the primary cancers and all metastatic lesions might have a curative potential. So that means we know that there's a small primary maybe there is a metastasis, or a large lesion with 1 or 2 lesions. It may not be just patient is in a good condition and general condition is good, and if they treat them effectively, actually we can go into a definitive intent or a curative potential. So another terminology to introduce is a definitive treatment. So that is very important. So there are a lot of oligometastatic definitions. I don't want to go in detail about this. What is there? What we are looking at that the histology is very important, the outcome, and disease burden. How much is the disease burden? Age of the patient, histopathology, and disease type, and alternative hypothesis where see that, like if you treat the primary area with the metastatic disease, what we call as the cancer stem cells, once it is controlled, and if you go and treat the other metastatic sites, there is a chance of potentially that definitive or a curative intent, and good quality of life and extensibility of the disease can be achieved. So that is what we are doing. So there is a metastatic disease, maybe oligometastasis, it in synchronous manner when the patient comes with the presence with the oligometastasis, and in a metachronous manner. So this is also considered to be the different baskets actually we can see, and you can differentiate. Oligoprogression is another terminology what we use. Even in a metastatic disease, when you do the PET CT scans, by the way, the PET CT scan is one of the gold standard investigations to do it as a first workup and as a baseline, and when to follow up in terms of response to treatment, even up to 2 years, 5 years is required. There are metastatic lesions which is all under control or a stable disease. One particular metastasis is growing, so that's called oligoprogression, or one residual lesion which is active and the rest of the things are gone, that is called oligoresidual tumor, or oligoprimary with tumor which is there. So these are some of the things, and oligopersistence. So if you treat those areas with the SBRT, there is a chances of extensibility of the disease. The natural history of mainly we are looking at the prostate cancer, breast cancer, colon cancer, and lung cancers, especially in these cases, and we want that the extensibility of the disease should be considered. So we have seen, if you see, the disease may progress over a period of time, polymetastatic disease, and then jump like it's to the incurable disease or the disease progression. In these cases, the intermediate state, if you treat them properly, especially in the prostate cancer, all metastatic sites and the primary area, even in a metastatic setup, even in their hormones, if you treat, we have seen the extensibility of the disease. So I will show our own data where we have seen that like 10-year survival, the median survival is 10 years. So the multiple theories are told, seed and soil theory is one of them. There is, I don't want to go into detail. The biology of oligometastasis, one cell has gone, that not necessarily that there are multiple cells which is present in that area. And see, there is different classifications we use, favorable oligometastatic disease and unfavorable metastatic disease, where we can help in terms of treatment management. So in terms of it's also same for in terms of that identifying the sweet spot, we call it as like we are given that you need to segregate, choose your patients so that if the general condition is good, extensibility of the disease is possible and there is no biology of the tumor in control, we can consider for treating these areas. There are a lot of algorithms which are there. So there's an established treatment options right now in the metastatic diseases. Don't just pull it that, okay, the metastatic disease, nothing can be done. No, it is not true. And the addition of now the immunotherapy is another treatment which has come up in a big way, and you can use this and we have seen a dramatic responses in this metastatic disease as well. Now in immunotherapy is a separate topic by itself. So we see in early cases, metastatic cases, residual tumors, and concurrently with the other modalities of treatment is coming in a big way. So especially with the SBRT with combination of immunotherapy works better. So that is keep it in mind. So breast cancer with metastasis, bony metastasis, we consider still it as a curative intent. So like the doses, maybe we go and treat only those areas and the continue chemotherapy and the treatment, the newer treatment options what we have with the newer linear accelerators are very focused, and the treatment related side effects are very, very less. And the prostate cancer, as I already told you, lung cancer and the colon cancers, they're all, if you see, there are enough literature available right now where going and treating these metastatic radiations with a short course of treatment with SPRT has shown a disease-free survival. Local control is in the range of 80 to 85%, range from 60 to 95%. If you say like it's around 80%, definitely local control is there. In terms of like the quality of life also increases. And then when it comes to the matter of like the extensibility of the disease, definitely there is the survival advantage in case of like NSCLC, if you see, ranging from 20 months to 44 months or 5 months. Or in case of prostate cancers, I can tell confidently it's more than 5 years definitely. So the aim of the treatment, even in a metastatic disease, oligometastasis, they should reach a double digit. So that is what the aim. And we can go and retreat the areas if it comes new, if the systemic treatment is not really acting. So there is enough. In NSCLCs, if you say 10 years back, it is considered to be one of the deadly disease. Now lung cancers with the driver mutations or whatever it is, we can reach easily 8 to 10 years, even if it may be a brain metastasis or multiple metastasis. Breast cancer, triple negative breast cancer is one of the deadliest diseases which is known for the metastasis. It can also be considered. There's enough radiation combinations trials are going on. So how we do in HCG is history and clinical examination. There is no alternative to consider. They should always be there. As and required, some of the pulmonary function test and the test is mandatory. We consider for biopsy from the metastatic site and confirm. And genomics is another place where it plays a major role in case of metastatic disease. There may be changes. Even if there is a metastasis, we go and redo the genomics in the metastatic site, and we have seen some of the changes. PET scan and art is important for radiotherapy planning, and MRI is also correct staging. Multidisciplinary team approach is very, very important. Each case is to be discussed in MDT, and that gives a insight, how much I can do, how much I cannot do it. And in the point, the patient-centric approach really makes a difference, and also it's in terms of legality also it helps. So what is SBRT? What we are looking at in a normal radiations, we talk about the radiation to the particular organ, the gross tumor volumes. We call it as volume, the treatment volumes, where with the tumor, with the margins, we give margins to these sites, and organs at risk are saved. In case of SBRTs, we choose in such a way that the organs are, the target volumes are marked very, very correctly. That's with the help of the PET scan and MRI. No really big margins of microscopic margins or clinical target volume is considered. And the radiation fall is very, very high. It's very accurate. We continuously track the tumor so that it won't, the surrounding normal structures gets very, very less dose. And because it's only 5 fractions, up to 5 to 6 fractions, large doses given in a short durations, the 6 weeks of radiation is given in 5 to 6 days. It has a multiple immunomodulatory effect that is important. That is what we are looking at. The SBRT can be delivered in many of the platforms. We use Cyberknife because the tracking is very, very good in case of Cyberknife, and the quality of life and the patients, the outcomes are better with that. You can go up to the protons also for the SBRT is considered. So what is Cyberknife? Cyberknife is nothing but a linear accelerator mounted on a robotic arm. So these are small videos. So we do the PET CT scan as a routinely and the MRI as a routinely as a part of the package. Wherever there's a soft tissue, we introduce the gold seeds and wait for 3 to 5 days. So once the patient comes, so this lies down with a minimal immobilization device. Actually the patient can be considered for when the targets are marked, and once the target are marked, whenever there is a respiratory pattern is there, we follow the respiratory patterns with the help of the synchrony system. And wherever, if there is a brain, we use 4 types of one. The brain skull tracking, spine tracking, fiducial tracking, and lung tracking. It can treat across the body. It can treat the brain tumors. We are talking on the benign tumors, schwannomas, CP angle tumors, and pituitary adenomas, meningiomas, recurrent brain tumors, or inoperable brain tumors. And then lung tumors, primary lung, primary liver cancers, liver metastasis, lung metastasis, pancreatic cancers where we talk about inoperable. Our patient does not want surgery. Our local control rate is in the range of 85 to 90%. 3-year survival rate is crossed 50%. So there is a lot of, among our own colleagues, we were not aware of that. One of the important thing in the tracking method in case of lung is difference between the LINAC. So we don't give margins because of the respiratory pattern. The lung tissue which is exposed to the radiation becomes less. All these patients has to be followed up. What we call it as a precision tracking, motion management, high dose delivery, rapid dose fall, and patient friendly. So SBRT for oligomets, the controversies are treat mets alone, treat primary, treat both primary and met. I prefer to treat all. I'm doing for last 16 years. I prefer both the places, treat primary and both. Now it has shown that immunotherapy and abscopal effect, those are the newer things. Main advantages of SBRT for oligomets, it's only 5 days of treatment. It doesn't interfere with the planned primary treatment of the chemotherapy or other things. Accurate, focused high dose radiation. Radiobiological advantages, it's very effective. No delay in systemic therapy. no control equivalent to the local control equivalent to the surgery. It's like a berry picking, and immune stimulation of the tumor, synergistic effect with immunotherapy. We do immunotherapy day 1 and then continue 5 days. It has shown a benefit as a immunomodulator. No repair in between the fractions, no repopulation, vascular damage, no redistribution, and immune stimulation. So these are the main advantages. I'll just show in 5 minutes our case, some of the cases what we have seen. So we are doing for the last 13 years, probably the largest in the country, around 5,000 plus cases. My contribution is around 3,500 and around 5,000 sites. If you take a multiple sites, we have done around more than 5,000 sites. And these are some of the metastatic directed. Another terminology in oligometastasis is metastatic directed therapy, which is important. It may be a surgical approach or the radiation. SBRT plays a major role in this. So these are the number of cases what we have done. We have published our data. This is the first prostate cancer data with 35 cases where we have seen treating the primary and the metastatic sites and continuing the hormones. Actually, the 5-year survival rate was 87.5%. Median overall survival was estimated to me 117 months. So 10 years is not a like difficult thing in a prostate cancer with a metastasis in more than 90 to 95% of the patients. So this is another one is the NSCLCs with immunotherapy and without immunotherapy in SBRT. Even in the worst prognostic site of oligometastasis, we have seen a survival advantage and it is safe. And we do how to identify that the patient are responding to these things. Immunomodulatory effects, immune scoring is one of the things what we are doing. We have published over it also. Hyperthermia is another one. We use hyperthermia in case of hepatocellular carcinoma to like increase the effect of the SBRT and the immunotherapy. It acts as an immunomodulatory effect. Well, that is also we have published over. And immunotherapy and SBRT in case of HCCs. HCC, if you see, we saw only 6 to 8 months survival in the past, but now with the immunotherapy and bevacizumab, we have seen definitely the good results. Whenever there is a residual tumor, you can always go back and consider for surgery, transplant versus local liver-directed therapy with SBRT. Size is not really an important criteria. Multiple things are not a problem. Minimum of 20% of normal liver is good enough for me to recover. So some of these things is very, very, and the same with the liver metastasis, colon with liver metastasis, and the SBRT. So we have published our polymetastatic disease. Oligomets actually I have achieved, even in polymetastatic disease, go and treat only the areas where it is causing problem. So you can still, we have seen that the survival advantages. Our local control, actually the range was 85 to 90% is the local control, and systemic control is very, very important in these cases. Multiple brain metastasis is another area. The moment if the brain mets occurs, the people will give it up and thinking that nothing can be done. No, it is not true. We can consider for surgical approach if surgery is possible. If there is multiple, even if the biggest one, you can consider for surgery. Go back and consider for the other areas with the SBRT. Whole brain radiation is absolute. We don't follow much of those. Only if the lesions are more than 5 or 10, and if the duration is of the metastasis is very early, that is the only time. Even in those cases, we do what we call as the hippocampal sparing radiotherapy with Cyberknife boost. The treatment of the metastatic sites should also get a radical dose. Unless if you do a half-hearted treatment and reduce the radiation as a palliative one versus increasing the dose to the full dose, will have a local control of the range of 85 to 90% with a good survival. Re-irradiation, yes, it is possible in any cases with the help of the Cyberknife, and we can definitely consider. So this is some of the cases. There's a clear lung with brain metastasis. So 2019, we treated both the areas and continued the targeted agents. So in 2021, there is if you see the PET scan, there is a complete resolution of both the lung and the brain lesion. She developed 3 new lesions after 4 years. We treated with the whole brain along with the Cyberknife boost with the hippocampal sparing. In case of vertebral metastasis, it is same. We don't treat one above, one below, treat only that area. To the segment, the extent of segment, even re-irradiation is possible in these cases, and it shows a very good response. If you see that blue lines, actually those are the one which is more than 300, 400 beams comes and concentrate. Patient comfort is very, very important. They can stop in between, go back and come, take a break and come and treat. That's no issue to start from the area where it is left. So these are larger lesions in the lung. So it is not necessarily like the lesion has to be a coin shaped, 3 centimeter less and all. No, I've treated even at an average of 10 centimeter, 12 centimeter, and if the lesion is more than that also we'll do. This is one of the patients with immunotherapy where the patient responded, but they couldn't continue the immunotherapy because of financial status, and this is progressed. We are not here to make people immortal, but definitely extensibility of the disease with good quality of life is the one what we are looking at. So this is some of the combination with immunotherapy in breast cancer. Mediastinal recurrences is one of the most common in breast cancers if you just start treating for a long time. So you consider for even the multiple areas can be treated. The same patient developed brain metastasis with immunotherapy and Cyberknife alone. Actually, she had a complete response, which is sustained for 2 years after the whole brain metastasis. The age is not a criteria. In fact, the older age patient who cannot lie down for a long time, this is the best treatment even in any of the sites. Lung, liver, pancreas, the surgery is not possible. Prostate cancers, there's another urinary bladder tumor with a liver recurrence. We treated, and you can see that it's a large tumor, 82 years. The people were resistant to send, but we have treated, and you see the response. Carcinoma in colon with liver metastasis is a huge tumor. When the patient came, actually, we had 3 lines of chemotherapy, used liver lesions, not even 15% was there. When we put the fiducials, actually he bled it for a long one, and then we continued immunotherapy with Cyberknife. He has a complete response. He is the 6th year running with immunotherapy, having a complete response. To conclude, actually, oligometastatic disease is a separate entity where, as an oncologist, we need to look into that. Don't have to put it into a basket of palliative all the time. And high and low volume, the timing is important. I prefer to treat upfront as much as possible rather than giving chemotherapy because action will be better. And SBRT for radical dose versus palliative, I prefer to give a full dose to that area. And re-irradiation is possible. Immunotherapy and combination is wonderful. I thank my team, and I appreciate your patience hearing. Thank you.
Thank you very much, sir. To felicitate, sir, I request Dr. Ashok Patel and Dr. Mansukh Gattiwala to please come over on stage. As they're coming in, I think a major announcement that in the afternoon, again in this very hall, we have the plenary session, right? And I think it's going to be an amazing session because we have 2 huge colossus people who are going to be speaking on the hospital past, present and the future, and also an integral topic which is insurance. So Dr. Ravi and Dr. Mangesh both will be here for the plenary session. So I request all of you not to miss it. Also the 4th coupon will be given at that time, so don't miss that too.
If patients are canvas, lasers are brushes. For a